Hello friends, myself Dr. Vivek Patel. I am a consultant endocrinologist from Ahmedabad. Today we are going to discuss an interesting case of 49-year-old male patient who is an corporate executive presented with uncontrolled type 2 diabetes. Patient had a history of diabetes for past 6 months and patient was initially initiated with metformin 500 milligram twice daily. Dose was gradually increased to 1 gram twice daily after 6 months when HbA1c was not under control. Patient has a family history of diabetes, hypertension, and coronary artery disease. Patient is also taking medicines for hypertension and dyslipidemia. On examination, patient weight is 85 kg with BMI of 28. Blood pressure is 134 by 82 with heart rate of 78 per minute. Patient current medications are metformin 1 gram twice daily with amlodipine and telmisartan combination for hypertension and rosuvastatin 20 milligram once daily for dyslipidemia. On lab investigation, patient has HbA1c of 8.7% with fasting and postprandial of 200 and 250. Patient lipid profile, EGFR, creatinine were normal. On fundus examination, there was no retinopathy and cardiac evaluation was normal. So this was the case coming to us with an uncontrolled diabetes, very recent onset and patient already on metformin twice daily. So in this kind of patient, what should be our approach to treating this patient? First of all, we have to decide what should be the individualized target of HbA1c for this patient. So looking at the patient condition of 49 years of age, no comorbidities, patient is active corporate executive, we should target HbA1c of less than 7%, even less than 6.5% would be better if we can achieve that target without any hypoglycemic episode. Also, we need to consider in this patient that HbA1c is beyond, patient current HbA1c is beyond 1.5% above the target, and therefore we have to apply a proactive approach to achieve a good glycemic control very rapidly. Many of the studies, especially the large studies of UKPDS, already shown that whenever we achieve a good glycemic control early in the stage of diabetes, it has a good metabolic memory or the good legacy effect so that we can prevent long-term microvascular as well as macrovascular complication. So in this patient, if we see the HbA1c is more than 1.5% above the patient individualized target, so in this patient, we try to uh, give patient a combination therapy so that we can avoid clinical inertia and we can achieve a good glycemic control very rapidly. Also, another factor we need to consider in this patient is that now our approach towards the diabetes management has changed from glucocentric approach. We are not just targeting fasting, postprandial or HbA1c, but we have to target overall cardiometabolic risk of the patient. As we already know that our patient is already having hypertension, dyslipidemia, and also strong family history of coronary artery disease. In this kind of patient, we try to reduce cardiovascular risk of the patient by adequately controlling glucose, blood pressure, dyslipidemia, and also using those kind of anti-diabetic medication which has shown to reduce cardiometabolic risk over a period of time. If we talk about the newer molecules which we are having, particularly SGLT2 inhibitor, which has shown in a large CVOT outcome trials that it reduces significantly cardiovascular events in the high-risk patient. Also, we have to consider the durability of the therapy because this patient is still in a very young and active phase of life. And if we start with a therapy which has a very durable glycemic control, we can provide patient a very long complication-free life with a good glycemic control. Now, if we see the different kind of molecules in this patient, add-on therapy to metformin, we can consider we have different molecules available, but the guidelines have changed over a period of time, and now they've suggested that early combination therapy rather than sequential therapy is a norm. And to reduce the cardiovascular risk, definitely we have to include SGLT2 inhibitor or GLP-1 analog in this kind of patient. If we talk about the SGLT2 inhibitor alone, again, as I already mentioned, that HbA1c is more than 1.5% of our individualized target. SGLT2 inhibitor alone will not be able to achieve HbA1c of our target. And therefore, we have to consider something in addition to SGLT2 inhibitor. And again, with the DPP4 inhibitor available and also the fixed drug combination of empagliflozin and linagliptin, which is available, which not only reduces the pill burden but also addresses all our concerns in this patient, would be the best option for this patient to go ahead. So let us talk about what will be the beneficial effects or what are the advantage of combination of empagliflozin and linagliptin in particular patient. So there is early and rapid glycemic control with addition of empagliflozin and linagliptin. The studies have shown that the reduction of HbA1c is greater than the individual empagliflozin or linagliptin alone. We can achieve HbA1c of HbA1c reduction of 1.8 to even 2% depending on baseline HbA1c, baseline BMI of the patient. That kind of HbA1c we can expect. Not only that, there are studies which have shown that in an Asian Indian phenotype, especially in an Indian patient, the effect of DPP4 inhibitor or empagliflozin is better as compared to the Western population. So that we can expect of HbA1c reduction of around 1.8 to 2% with this combination therapy, and we can achieve the target HbA1c of 6.5% in our majority of patients. Not only that, this combination is also very durable. The glycemic control which we achieve is also maintained over a period of time and without requirement of further intensification of therapy. And this is because of mainly mechanism of action of this molecule. Both the molecule working synergistically and they have a complementary mechanism of action targeting different pathophysiological defects of type 2 diabetes. Not only that, the extra glycemic benefit of this molecule are also well known. With empagliflozin, we can expect weight loss of around 2 to 3 kg with reduction in systolic blood pressure, favorable effects on lipids, favorable effect on uric acid, and overall this will translate into long-term cardiovascular as well as the renal benefit. If we talk about the linagliptin, it is majoritarily safe. It is cardiovascular neutral, no harmful effect on weight, no risk of hyperglycemia, and therefore this combination gives us the maximum benefit in terms of the cardiovascular as well as the renal outcome. Also, in the studies, that is CVOT outcome trial, EMPAREC, as well as Carmelina studies, which have shown that this molecule are cardiovascular safe and cardiovascular beneficial over a long run. Also, there is a possible reduction in the genital tract infection when we are using fixed drug combination of empagliflozin and linagliptin. The mechanisms were not known, but the studies have clearly shown that with the use of fixed drug combination, the genital tract infection associated with empagliflozin can be reduced in the patient, which is a very cumbersome side effect for the patient. So overall, if we see if we return to our case, what has been done in the patient is continued on metformin 1000 milligram twice daily, and patient was added empagliflozin linagliptin fixed drug combination on the top of metformin. If we see the follow-up, during the follow-up visit, patient HbA1c was controlled. HbA1c reached to 6.5% with good fasting and postprandial control and weight loss of around 5 kg. Patient has lost 5 kg of weight also. Patient has advised to continue on the same regime for further with regular follow-up. So, to summarize, I would say that empagliflozin linagliptin combination provides robust HbA1c reduction and 2 to 4 times higher odds that patient will achieve good glycemic control with minimum risk of hypoglycemia and additional weight benefit. All this because of complementary and synergistic effect of empagliflozin and linagliptin. Along with all this, we also have the extra glycemic benefits of cardiovascular and renal outcome and possible reduction in the genital tract infection. So, friends, I would like to highlight here that in a patient who is uncontrolled on metformin monotherapy, especially who he is in the high risk category for cardiovascular or the renal risk, the combination of empagliflozin and linagliptin early in the stage of diabetes would help patient not only to achieve good glycemic control but also a good weight loss and also the long-term uh, cardiovascular and renal benefits so that patient can have a long healthy life without cardiovascular or the renal morbidities. Thank you. Thank you for your patience.